Hi everybody. Thanks for having Dr. Schonfeld here. He has been extremely helpful with us, to us pediatricians in our whole community in Maui. He is the founder for National Center for School Crisis and Bereavement, and has had such broad experience from helping out with September 11th, Katrina, so many crises around the country, and we are so honored to have him here in Maui. Actually, this week we just met with him and many of our local pediatricians, as well as the U.S. Public Health Corps yesterday for dinner. I think that in Maui, he has changed our vocabulary and the way we deal with trauma, how he has helped us just approach and get comfortable with patients sharing their grief with us. And I just welcome you and am honored to hear him speak. So thank you, Dr. Schonfeld, for helping Maui and for helping us Hawaii pediatricians. Thank you.
It's been my pleasure, and thank you for hosting these two visits. So I'm going to start by just sharing that I have no relevant financial disclosures, and I'm not going to be talking about any medications or products, whether FDA approved or not. What instead I'm going to be talking about is really how do we support children, families, as well as ourselves in the aftermath of the wildfires here in Maui, but it's also applicable to other crisis events. And in fact, it'll be applicable to dealing with personal and family crises that affect your patients as well. So chances are you will use this in your daily practice, even outside of another disaster. So I wanted to start to say a little bit about kind of the philosophy that I have and our center has used that guides some of the work that we do. And part of that is that a school or a community response to a crisis is not the same as a clinical approach that's applied to every child that's either in the school or the community. So particularly in the aftermath of very large-scale disasters like we're seeing here in Maui, we really need to shift from using exclusively a medical model. And the medical model would be that you're screening and then doing evaluation, diagnosis, and referral for treatment of individual children that you feel have a mental illness or at least have a high likelihood of a mental illness, and move away from that as your predominant approach and move instead more to a system of universal support as the primary response to major crisis events. So that would be focusing on building resilience rather than delivering treatment. And this is really, predicated on the fact that in very large disasters, you don't have the resources or the capacity to be able to try and do clinical work with every individual child, but also most people will not receive clinical care and often don't require clinical care. So it's really better to, I think, have as your predominant approach this kind of universal support and resiliency building. Now that does have to be incorporated with, having mental health professionals both in school, community-based, and co-located in healthcare systems so you can provide the additional support to children who do require more assistance. So it isn't that you don't provide clinical services to individuals, but your predominant approach should be more universal in building resiliency. So one way of doing that in the immediate aftermath of a major crisis event is referred to as psychological first aid. And that should be provided broadly to all of those who have been impacted by the event, and involves offering psychoeducation, which helps people understand the likely impact of a crisis event, and more importantly, what can you do in practical steps to be able to cope with those impacts. It also involves supportive services with the goal of trying to promote effective and normative coping. And what you're really trying to do is accelerate the natural healing process. So again, it's not a treatment, it is instead a supportive intervention. And all adults that are working with children should understand the likely reactions to stress that you will see among both children and adults and how to help them cope. Because anyone that interacts with children and their families can be a potential source of assistance and support, but if they're unprepared, particularly if they appear disinterested or unwilling to help, they can actually turn into a source of further distress. And I always tell people your practice is going to be known by the one insensitive comment that a staff member says, often that has a limited interaction with patients. It might even just be a security person, or it could be someone in the parking garage. If they say something that seems insensitive, like, I don't really care whether or not your child is is in the emergency department, you still have to park your car legally. Those type of comments really shape how people view the entire system. I was doing some training for the Flight 93 Memorial. It's outside Pittsburgh. So Flight 93 on 9/11 had terrorists on board. So it did not land when all the planes were instructed to land. And the passengers on board the plane and the crew became aware of what had happened at the World Trade Center through cell phone communications. And they were aware that there were terrorists on board the plane. And so they collectively decided to try and overpower the terrorists rather than allow their plane to be used for similar destruction that occurred to the World Trade Center and the Pentagon. And so that plane crashed outside of Pittsburgh. And so there is a national park that's dedicated in the honor of the passengers and crew. And there also is a visitor center that goes over their story. And for those of you who haven't been there, it's really a very nice place to visit. But I was doing training to some of their staff, and I remember one person came up and identified himself as someone that oversees some of the groundskeeping at the park. And he said to me that he trained the people that if they're cutting their lawn and they see a visitor, they're to stop what they're doing, establish eye contact, and ask if they can be of assistance. And he looked at me and he said, we're not here for the lawn. This is sacred ground. We're here for the visitor experience. Now, part of me felt like saying, well, actually, you are part of the National Park Service and you are here to cut the lawn. That is your job. So I don't think that was disputed by anyone. But the point he was making is that there is a higher purpose to what they do on that site. And I would say that's the attitude we really need of everyone. If you work in a healthcare setting, you are there for the patient experience. And so no matter what your actual job is, that is part of your mission. And you need to make sure that everyone knows how to do that and also shares in that mission. And that's how we'll provide exemplary care to patients and to their families. So let me go over very briefly what are some of the steps in psychological first aid as described by the American Red Cross. So the first is observation or awareness. And I'm going to go over some of the common symptoms of adjustment difficulties that may be seen in children. Then you want to make a connection, help people feel comfortable and at ease, and be kind, calm, and compassionate. People tend to pick up on how we present ourselves rather than what we actually say when they're in crisis events. So I remember being and attending in the emergency department when a child came in after a head injury during a baseball game. So he was in the treatment room and he was receiving care, and his mother arrived because he had been transported from the school. So I sat down with her, and I'm told I'm very calming. So in this type of presentation, I just said, ma'am, your son is in the back now getting treatment. He was in an accident at the baseball game. Someone hit him with a bat in the head very hard. And it was so hard that there was a fracture or a small break in the skull. And we know that the skull is lined with small blood vessels, and one of them ruptured or started to bleed, and when the skull fractured in that area. And as a result, there's some blood collecting and pushing down on the brain. That is an emergency. And so what we need to do is take him quickly to the operating room where they'll take some of that blood out so that it doesn't put pressure on the brain anymore. But in the meantime, we need him to breathe extremely quickly. So what we do is we put a tube into his lungs and put him on a breathing machine so the machine can breathe at a rate faster than he would be able to breathe on his own. And that decreases the pressure for a period of time. So that's about all I said. And I looked at her and I asked, do you have any questions before we go see him? And she just looked at me and asked, is he going to have to stay overnight? And I felt like saying, I really hope he will. But then I realized she was not getting this. So we went back to see him. And even though he was unconscious and intubated and bruised, and I thought looked pretty bad, she signed the paperwork for the neurosurgeon. She signed the paperwork for anesthesia. And then she looked at me and she just asked, should I go home now? And I was like, no. And then it's called tracking in our field. I changed the way I speak so that I modeled more what I wanted her to understand of the urgency of the situation. I don't normally do it, but I can. So I just looked at her and I said, ma'am, this is really serious. This pressure on the brain can cause fatal, outcomes. You really should be very concerned about how your child is doing. And she looks at me, she goes, oh, then I'll stay. And I just then said, oh, good. And, I went back to the way I normally speak. And her brother came in shortly thereafter. I gave the same explanation. He gave me the same question. Is he going to have to stay in the hospital overnight? And I thought, I don't know, do you have a party this evening that everyone's going to? But the point was that I appeared calm, and as a result, they felt calmer. So they weren't really thinking about what I was saying as much as they were reflecting how I delivered that message. So if you want people to be calmer, then the lesson is you really need to also present them the information in a calming way. The next thing is to assist with basic needs. So I often tell the story. I was in New Orleans a couple months after Katrina, and somebody told me that he had been at church over the weekend, and in the middle of the sermon, someone's cell phone went off in the congregation. The congregation was making murmuring sounds and how inappropriate it is to have your cell phone on. And the minister apparently just stopped the sermon, turned to the congregation and said very simply, that call might be your contractor. You better answer it. What he communicated was that literally listening to the word of God is not as important right now as making sure that you and your family are safe. And I think that's the message we have to get out to people that are in Maui and in other places where they're having disasters, is that their basic needs are critical. And we need to make sure that they know we recognize that as well. I will say a lot of times pediatricians tell me, all I'm doing is making sure that families have formula and food and a place to live, but I don't really know what to do to support them. And I try and explain that is the first step to emotional support, is to make sure that their basic needs are met. The next step is to listen, and being able to actively listen is even more important than knowing exactly what to say. Give realistic reassurance, but not false reassurance. Encourage good coping strategies. So in other words, bad coping strategies would be things like the use of alcohol and other drugs. You want to give them some suggestions on good coping strategies. And then you help people connect. So help them find and identify supports in their family and in the community, including within your healthcare system. And then help them figure out also how they can help others. Because being able to help others is a good way to feel less powerless in the midst of a disaster and help you feel more connected to the needs of others. And then if the crisis is unfolding, as it still is to some extent in Maui, although the immediate danger may have passed, how they're going to respond to the damage that has occurred and meet the needs of the community is still evolving. And so what you want to do is give them accurate and timely information, but not give them unnecessary or graphic details. So during a crisis event, we really should be watching our media consumption and make sure that it's a healthy diet and you don't consume too much. Adults should try to keep informed through focused but periodic attention to trusted media outlets or other trusted sources of information. And pediatricians, by the way, can become that source of trusted information for families in the midst of a lot of conflicting information that's out in the media. You don't want to listen to, watch, or read continual coverage, as I think many people were doing during the pandemic, which was not helpful. It's good to kind of remind yourself there really are two main reasons to listen to, watch, or read media coverage. One is to be reassured, and the other is to learn practical strategies to keep yourself and those you care about safer from whatever the risk is. So if you're listening to the media or watching it or reading it, and you're not becoming more reassured, and you're not learning any new practical information that you need to take, like in the midst of the pandemic, you're hearing about the fact that there are new variants of a virus, which by the way happen continuously, but they're new variants that are spreading. We don't know whether or not they're more dangerous or more likely to kill you than the other ones. And you really do the same things we've already been telling you, such as wash your hands, put a mask on, keep a distance from people. Those type of messages are not useful because all they're doing is telling you to be more scared. They're not giving you any practical information about what you can do differently, and they're not reassuring. So when you find you're not learning new information and you're just getting more agitated, then that's a good time to just disconnect from media, whether that's television, print, or social media, at least for a period of time. And we should be advising children to limit their media consumption, and also adults, and we should be following that practice ourselves. The aftermath of a crisis is actually a good time for people to unplug from different devices and instead connect with family and friends in person if you're able to, remotely if the situation doesn't allow you to do it in person. So getting back to the steps, next you want to suggest a referral resource. So become aware of both school and community mental health resources, as well as those in your healthcare setting, so you can offer them to families in a crisis situation. And then the last step is to end the conversation. The way psychological first aid is designed, it's meant to be done not necessarily by healthcare providers, but instead by lay people with limited training, who interact with people that they will have one-time interactions with, they don't know beforehand and won't be following up with them. And it's often meant to be done in about 10 to 15 minutes. But you can employ some of these same strategies within whatever your practice setting is, and you can also use this for people you run into in the hallways or in the lobbies or in the waiting room of healthcare settings. Now, so I went very quickly through what psychological first aid is, and I hope you will share that with the staff that work with you in your setting so you can make sure everyone does something similar. Now, parents and other adults that support children, whether those are healthcare providers or whether those are educators, they tend to actually underestimate the extent of children's reactions to a crisis event. If we do a good job, and this is hard enough on its own, if we do a good job, we can observe children's behavior, but you can't observe children's feelings, particularly if they don't express it in an outward way. We can't see how they feel. They have to tell us how they feel. And so we tend to underestimate the distress that they're having, particularly internal distress. This is one of the posters that was used by Project Liberty in New York City. They started to be posted about 6 months after 9/11, and they all had the same message, if only the signs were this easy to read, because they are not that easy to read. And children may actually withhold complaints of their reactions because of concerns that it makes them abnormal, or at least somehow they're inappropriate, or sometimes they just want to protect their parents and other adults around them who are visibly upset. And adults are often then afraid to start these discussions with children when there are troubling events, because they don't want to contribute to their distress, and they're afraid they're just going to upset them or say or do the wrong thing and make matters worse. I have a lot of times people tell me, if you don't know exactly what to say, it's best to say nothing. But I tell them saying nothing is precisely the wrong thing to say, because it communicates to children either that you're incredibly clueless and you don't know yourself what's happened, or you're unconcerned about what's happened, or you know what's happened, but you don't think the child can handle it, even if you do try and offer support, or you're just unable or frankly just unwilling to be of assistance to children. I think all of those are really bad messages in a crisis setting. It applies not to children, but also to adults and extended families of our patients. And so we really do need to say something, and should often be starting the conversation. So let me go over some of the reactions that you may see in children when there's been a major crisis event. Now, one of the first steps that it does involve recognizing the problems that children are having, but often what you will find, and for some reason that slide is missing, so I apologize. I'll just go over the different things that you may see. So one of them is fears. So you can see fears and anxiety in children. So the fears may be related directly to the crisis event. So for example, if there's been a wildfire, they may be afraid that there will be another fire. If there is a hurricane that's occurred, they may become fearful when there has been severe weather, such as heavy rain, that something similar is happening or may happen again. But they can also just be anxious. And those are fears that are not directly related to the crisis event. So they may become more fearful of the dark, for example, even if the wildfires occurred during daylight. So they start to become just more fearful. One of the fears that commonly you'll see in children is school avoidance. And that occurs even if the natural disaster happened on the weekends or during summer breaks when kids were home with their families. They still don't want to separate from those that they care about when they're in the aftermath of the disaster. They may worry that something is going to happen to them if their parents aren't there to protect them, or that something may happen to their parents, their guardians, or siblings, or extended family members, if the child is not somehow there to protect them in turn. So what you will find is that they will often be reluctant to return to school and other social settings. And so if there's one bit of advice that I can give to pediatric healthcare providers, when you are asked, please do not write letters of medical necessity for home-based education in children who have school avoidance. The treatment for school avoidance is having a graduated return back to a school-like setting as soon as possible, giving adequate support and accommodations. But the opposite of that is to maintain them at home with no attempt for them to return back to a school setting. So please, instead of writing a letter of medical necessity, instead get in touch with the school and figure out how you can help support the safe transition of children back into school settings. In terms of fears, though, you also want to find out what is the child actually afraid of and what are their concerns. I think we tend to move very quickly towards reassurance before we really know what the person is actually scared about. And children, as we know, often have very different fears than the adults do. And you can't reassure people if you don't know what they're afraid of or personally concerned about. Otherwise, you're really not offering reassurance, but instead you're telling them why you aren't scared. And if the child is telling you they're scared and you're talking about why you're not scared, then each person is coming from their own perspective. And I call that arguing. And so it isn't reassuring to children. So what you really need to do is start by finding out, why are you concerned? Tell me a little bit more about it. So I'm going to give you an example that was not from a crisis event. It was actually occurring in pediatric walk-in clinic where I was attending many years ago. And the clinic was open Monday to Friday and closed on Friday at like 4:30 or something like that. And it was about 5:30 in the afternoon, and we were trying to, either decide whether children needed to be transported to the emergency department for further care or were safe to return home or had to be admitted to the hospital. And it was flu season, and there were a number of kids who had been dehydrated and were finishing IV hydration. So there were two families in two different rooms that each had the same issue. I had a toddler who had gone through IV hydration, was determined to be well enough hydrated to go home, but the family was not willing to go home and said that the child needed further care. So the residents tried to reassure them, but they reassured them based on what was reassuring to them. So they talked about the urine-specific gravity, the electrolytes, the hydration status, the skin turgor. None of this was working with the families. They just kept saying, no, my child isn't ready. You can't send him home. So I went in, and I remember the first family I asked, what are you concerned about? They said, well, I don't think my child will drink anymore this evening. And I said, well, what do you think is going to happen if your child doesn't drink this evening? And he looked at me and he said, well, she'll get dehydrated again. I go, and what are you concerned about with dehydration? What would be the worst that you think might happen? And he looked at me and said, she could die of dehydration. And I asked him, how long do you think that takes? And he said, I have no idea, because he didn't have any idea. So I looked at him and I said, well, your child's like, I don't remember, like 12 months. I said, when does your child usually go to sleep? And he says, well, in about an hour or two. And I said, okay. And does the child wake up to drink during the night? And he says, no, not anymore. And I said, okay, so we have already given enough fluids that if your child goes to sleep now and doesn't wake up or take another drop in, she's not going to get dehydrated by tomorrow morning. And the clinic opens at 9 a.m. and we can see you then. Now, if your child starts vomiting or has diarrhea and is losing a lot of fluids, then you can call us and maybe we'll see her again at night. But in the absence of that, and she hasn't had that yet, she should be fine to wait until tomorrow. So he looked at me and he goes, oh, okay, then I'll go home and I'll come back tomorrow morning. Then I went into the other room and I asked the mother what she was concerned about. And she said, I don't think he's well enough to go home. And I said, well, what do you think is going to happen? She looked at me and she goes, well, I think he's just going to cry all night. And I said, and what are you concerned about if he cries all night? And she looked at me and she said, well, I am in a drug rehab program. I have stopped using cocaine, but I've been up for the past couple nights because he's been crying. And I'm worried if he cries tonight, I'm going to start using again, and then I will lose my child. And so I looked at her and I asked, would it be okay if we called someone at the treatment center to monitor you tonight or to help you in supporting your child so you could get some sleep or at least have the support you would need to be able to keep yourself safe through the evening? And she looked at me, she goes, oh yeah, you can call. And she goes, and if you do that, I can go and come home tomorrow. Or come back tomorrow. So the point was, they both made the same complaint. They both expressed the same fear at the surface. But when I delved a little deeper, they were very different. And so the issue is you need to spend the time to understand more about what people are truly afraid of before you start trying to offer reassurance, so that you tailor your reassurance to their personal concern. Now, I know some people will say to me, well, we don't really have the time to do that. Well, I will tell you, it took as long as I just went through. It was a matter of minutes. And I knew deep down that if they left, they were going straight to the emergency department, the emergency room would see them, would admit them, and I would be on the phone for an hour for each of them, trying to explain why we sent them to the emergency department when we actually hadn't done that. And I knew it would take much more time. It also would not be good care. And it was the latter that I was most concerned about. So returning to go over some of the different types of reactions you'll see, you also see sleep problems. That can be trouble falling asleep or staying asleep, difficulty waking in the morning, nightmares, or any disruption in sleep. And if people don't sleep well, they don't function well. And so we really need to make sure that people have adequate sleep. Now that doesn't, and so a lot of what I do when I'm meeting with families after there's been a major crisis event is really going over sleep hygiene. So I've done this work for over 30 years. I have never written a prescription for medication for sleep medication in the setting of a disaster or crisis. So I'm not suggesting that when we try and address sleep, we do that through sleep aids. The sleep medication doesn't actually help people learn how to sleep. It just makes them fall asleep, and then they become less capable of falling asleep on their own. So I'm not suggesting medication, but I am suggesting that go over what pediatricians do all the time about how do we promote healthy sleep in children and adults. You can also see changes in appetite or eating. It either increases or decreases. And so you want to be looking for those factors as well. You will also see difficulty with concentration, and that has an impact on both academic performance in children and work performance in adults. So in schools, after there have been major crisis events, the kids don't learn well, but the teachers don't teach well either. Everyone is usually not doing quite as well. And so I will say in discussions during the pandemic, because I was on the committee that was writing the safe reentry guidelines for schools and multiple iterations of it, I kept trying to point out to people, you do know that even when they go back to school, they're still not going to learn very well. I mean, it isn't just that they're getting remote education, it's that people are dying around them. You do realize that we will not solve this problem simply by getting them back into schools. We're still going to have the concerns, and I think that is playing out, and we see this all the time after disasters. The next is sadness and depression, and you really have to sort between the two. Sadness is expected after a sad event or crisis that occurred, and so that'll be nearly universal and is actually appropriate, but you want to make sure it's not clinical depression. It's not causing problems in day-to-day functioning or posing some danger to the well-being of the child. You will also see anger and irritability. Now, a lot of times I hear people say crisis brings out the best in people, and actually I've seen a lot of that in Maui. People have really come together. There's a strong sense of community. People are really helping each other. In most situations, though, that's an outlier. And we focus on it in the media, you know, the heroic things and selfless acts that people have. But I will tell you from my experience, crisis doesn't usually bring out the best in people. It brings out their distress. And sometimes the people just appear needy, demanding, self-centered, and dealing with that is not very pleasant for pediatric healthcare providers. We just have to realize it makes our work harder. And it is often not as satisfying as the work we do on a day-to-day basis. So if you're feeling a little irritable sometimes when you come back from work, just because you've met with a lot of people who seem particularly needy and upset, please understand that's understandable that you may feel that way. And often those who feel most out of control during a crisis try to exert additional control as soon as the opportunity arrives. So in the pandemic, I was warning people starting in like April of 2019, that as soon as we get to the point where we can open schools, people are not going to agree on when it's safe to do that, are not going to agree on how fast the academics should be geared back up. They're not going to agree on a lot of things. And while people often don't agree, they will be adamant about what they think is right. and they will try and exert their influence through, displays of being very aggressive during public meetings, of attacking people in social media and in public meetings. I see this all the time when I respond to crisis events. And so a lot of the political polarization and the attacks going on publicly, all anticipated. I'm not saying it's okay. I'm just saying that that is what we see. And that type of anger and irritability sometimes impacts the professionals as well. You may find that, I told people last night, I have been now at a couple different schools doing professional development after a crisis on the same day as they were voting on a strike vote. And I think as we start to see there's strikes in the healthcare system today, there's other things, people get more irritable, and things that were problems all along, I'm not saying they make up problems, but things that were problems all along sometimes just feel more intolerable when you've been through a crisis. The next thing I will say is another common reaction is alcohol and other substance use. And substance abuse evaluations and treatment services should be part of the recovery plan for any crisis. And it's also the case for adults. I remember responding to the earthquake in Sichuan province that killed 69,000 people. And a number of schools collapsed because of construction standards, or failure to follow those construction standards, I should say. And there were schools where, a quarter of the students and staff were killed when the building collapsed, and the others were buried alive and dug out. And I was talking to one of the teachers at a middle school that had gone through that. They had been relocated to a resettlement community, and we were literally standing in a tent. And I just asked him, how are the kids doing? And he said, well, they're middle school kids. They're smoking more tobacco. That's what they had access to. And I asked him, well, how are you doing? And I remember he didn't even pause. He was standing right next to his principal, and he simply said, I drink every night to fall asleep. The same thing happens among healthcare professionals as well. I responded to the Hurricane Katrina, and I was talking to one of the mental health professionals after I had done a workshop. She was hosting a visit. And she said to me, that statement that you made really kind of resonated with me, because it was about, she said it was about a month, maybe 3 weeks after Katrina. And she got a call on her cell phone one day after school asking where she was from her daughter. And she said, oh, don't worry, I'm with my friends from school. We're at happy hour. And she just said, Mom, you've been at happy hour every day since Katrina, and you don't seem happy at all to me. And she looked at me, she said, and I realized then I was drinking more. And so sometimes people don't notice it. And I will say, and I'm really not trying to be very critical, I just want you to be conscious of this, is that in the height of the pandemic, when people were, before vaccines were available and people were sheltering in place, I attended 2 virtual pediatric conferences for major organizations in 1 week. They were 1 week apart. Both of them had virtual happy hours. They encouraged people who were sheltering and isolated to get alcohol and sit in front of a computer screen. And I really thought that it's not what we should be asking people to do when they're highly stressed. So we have to think about whether we should be offering or even encouraging alcohol use in times of great stress. We will also see physical symptoms among children and adults like headaches or stomach aches. And in pediatrics, we say if it's sometimes psychological distress presents as a physical illness, then we call that, or physical symptom, we call that somatization. But also stress hormones can precipitate physical illness. They worsen diabetes control, increase blood pressure. They can precipitate asthma attacks in individuals who are susceptible to it. And it also can be that it's a combination of those. So if a kid's having respiratory distress and they're in school, you have to figure out, are they breathing quickly because they're having a panic attack, because they're infected with COVID, or because they're having an asthma attack because they're stressed. So it could be all 3 of them, or or a combination of them. So that's why I always say, please be kind to school nurses, because they end up often having to sort that out, just the same way I think pediatricians sort that out in their practice setting. Children may also demonstrate post-traumatic symptoms, and some will meet the criteria for post-traumatic stress disorder. And because I think we talk so much about being trauma-informed and about PTSD, for the purposes of just time, I'm not going to go over that, although I can discuss that in the questions if people have. But I think what I wanted to emphasize instead was grief, is also very common. So the pandemic caused widespread distress among children and adults, and so have the Maui wildfires. But not all of that distress is actually trauma symptoms. The challenges I think facing most children, particularly if they did not have experienced life threat during the event. So for example, if they were fleeing from flames and thought they might die, then they have a higher likelihood of actually having trauma and post-traumatic stress disorder. But if they did relocate prior, that their homes were destroyed and other disruptions in their life, those children are probably not experiencing trauma as much as they're experiencing grief and loss. So our society has of late grown to appreciate the important impact of trauma on children, and that's why we've had this call to become trauma informed, which is important, and we do need to address that. But we've been slower to recognize that we must also become grief sensitive. I remember responding, talking with a child. He attended an elementary school where the ex-spouse of the teacher had come back to the school and in front of the class had shot and killed his ex-wife. And in the process, he had also shot and killed a couple other students, we believe accidentally. So I was talking, and unfortunately it was a elementary school class, and it was a full-time special ed classroom. So he had some intellectual developmental disorder that made it harder for him to understand what had happened. Well, anyway, I was talking to the mother about a month later, and I asked her, was he close with his teacher? And she said, oh yeah, he had that teacher for 2 years, and that was the only teacher he had, and he was really extremely close with her. And I said, does he talk about missing her? And she looked at me and she just said, I never thought to ask. So the child had experienced trauma, but he had also experienced loss. And we tend not to think about that. And we often don't ask about it or provide the necessary supports. But the interventions and supports that we offer children who are grieving are actually quite different from trauma treatment. If you think about it at a very basic level, when you're dealing with trauma, you're trying to help somebody deal with something that happened. It could be complex trauma where the thing happened multiple times, but it's still something that happened or occurred. But grief is the opposite. It's helping people cope with the persistent absence of something that they loved. And so it's not the same thing. And what we do for one doesn't always work for the other. So I often talk about the fact I was on the Sandy Hook Advisory Commission, and a parent came at the end of the school year and so she opened the yearbook and found that the photograph of her child that died that day was missing. She said, as were the photographs of every child and adult who died that day. And she just looked at us, she said, what were they thinking? It's like they never existed. Now, I didn't talk with the yearbook committee in that particular school, so I don't know the reason why they didn't include it, but I have talked to other yearbooks after mass shootings and other events. And what they say to me often is, we don't want to include the pictures because they're trauma triggers. And I look at them and I go, they're not trauma triggers, they're grief triggers. And so they both trigger the emotion. Trauma triggers and grief triggers both trigger memories of what has happened and what we've lost or what we went through. But grief triggers are really expressions of the continued love we have for the person that died. And most people would prefer to experience those feelings rather than to forget the person that they love. That's why we have cemeteries, and we go back to the cemeteries, even though we know that will be upsetting, because not to stay connected is even worse. So what we do for trauma is not the same thing as what we do for grief. So you may have evidence-based trauma treatments, but they really only have their evidence-based to work for trauma symptoms and disorders, not for grief or bereavement. So the last one that's on that list, and I'll get you the corrected slides, is guilt. People manage to find reasons to feel guilty irrespective of their actual experience or role in the event. And at least at some level, often unconsciously, it may feel easier to feel responsible for something you did, didn't do, or should have done to prevent someone you care about from dying or being seriously injured, rather than to accept it actually had nothing to do with you. Because if it had nothing to do with you, that means it could easily happen again to someone else you care about, and there's probably nothing you can do about that. So you may find children that will say it was my fault because I didn't call my parents when I first realized that something was wrong. or I should have checked outside to see if there was a fire because I knew there were high winds. Whatever the reason is, they may feel that there was something they could have or should have done to have protected others. Or maybe I should have gone back into the house when we left just to make sure that my dog wasn't left behind. They start to wonder what they could have done to change it because they may want to adopt this illusion of control because it may make them feel it's less likely to occur again. And one of the anxieties that people have is that it will happen to someone else that they care about. So adopting that illusion of control may minimize that distress temporarily. The problem is it's an illusion of control. So it doesn't actually help you prevent it from happening again, but it leaves you with guilt. And the guilt impairs adjustment, as you would expect. We also see survivor guilt. People may feel badly that they have not experienced the same, that they survived, or just guilt for not having experienced the same type of loss or trauma as others. So you may feel guilty when your patients talk about all their loss and trauma if your home is intact, or maybe your home got destroyed, but no one, fortunately, no one died that you are attached to. And some people feel guilty about that because they feel that it's unfair, or that they shouldn't then be talking to other people about this. So we want to realize that guilt is extremely common. So Calvin talks about that. He calls for his mom and he says, a big dog knocked me down and he stole Hobbs. I tried to catch him, but I couldn't. And now I've lost my best friend. And his mother says, well, Calvin, if you wouldn't drag that tiger everywhere, things like this wouldn't happen. And he observes there's no problem so awful that you can't add some guilt to it and make it even worse. So please look for guilt. I see that happens all the time. And we need to reassure children and adults of their lack of responsibility. Now, these reactions may all be due to the particular crisis event, but it may also be due to a wide range of other stressors that are associated with the crisis. We don't just deal with a single crisis event, we deal with the cascade of secondary losses and crises that follow. So I remember talking with one teacher. She was living in an apartment that she rented in the French Quarter when Hurricane Katrina hit. She evacuated in time. Her apartment was completely undamaged, and she said she was lucky. She was only lucky for about 3 or 4 months. Then her lease ran out, and the landlord doubled her rent. She couldn't afford that, and she couldn't find affordable housing within a reasonable driving distance because that's why he had increased the rent. And on a teacher's salary, she couldn't afford it. So she moved about 45 minutes away, and she told me, I functionally live out of the trunk of my car now. But she had to remove her daughter from high school. And so her high school student got depressed, her daughter got depressed. She ended up in an emergency room, got her some antidepressants, but couldn't access counseling for her. So someone said, well, if you can't get counseling, why don't you get her a pet? So she went and she bought a dog for her, and the dog attacked someone else in the throat. And she looked at me and said, I'm going to be going to court next week. My attorney says it's likely I'm going to be bankrupt. So she didn't experience any loss of her home initially, and she didn't have PTSD from Hurricane Katrina, but her life was dramatically changed by everything that followed. And I think some of that is playing out now in Maui, as you would expect, that people are starting to have financial problems, loss of jobs, loss of health insurance, etc. And so you don't just deal with the event that happened on one day, you deal with everything that followed. And a crisis often awakens feelings related to a pre-existing or even a past crisis that may not be fully resolved, but may come to the surface when the individual is faced with the current crisis event. And that may occur even if the prior event isn't related. I went to one school shooting and a teacher met with me, and she came into the office and sat with me, and she looked at me, she talked about the fact that she was about 8 years old. There was a house fire, and she said, I was told that the only reason I didn't die was because I had my bedroom door closed that evening. And she looked at me, she goes, I make sure now whenever I'm in a room that the door is always closed. Now her back was to the door, and I looked up and she just looked at me and she said, oh, it's closed. I already checked before I sat down. So the issue is these events come to the surface when you've had other crises in your life because these are life-changing events. So I just wanted to go over 2 other things. So one is just what is the adjustment over time in crisis? And so I do want to say that events such as the fires in Maui are life-changing events, and that's what they do. We don't go back to never having been through it. They will change who we are as people. We're not necessarily damaged by these events, but we are changed. So if you think about it, there's adjustment over time. It's not a straight line. Something good happens to you or someone you care about, and you feel a little better one day, and something bad happens, and you feel distressed. Now, just because you feel distressed does not mean you are in crisis. So distress happens in people's lives, and if they are able to cope with it, it is not a crisis. Crisis is actually not defined by the event. It's defined by the person or the system's capacity to cope with the event in the absence of external support. Resiliency doesn't mean you don't experience distress. It simply means you have the skill and capacity to cope with it. And the reason I mention that is, as physicians, we often become more resilient to distressing situations, but it still is upsetting to us. We still should accept, and we should offer support to our peers. So just because you can cope with it doesn't mean it doesn't hurt. And so but let's say in this situation, you have exceeded the capacity for the individual or the system. And then they feel vulnerable, and then at point D, their usual coping mechanisms have failed. And what usually occurs is that resources come from outside and people. And so you're seeing some really wonderful people from really across the country, and I'm sure from outside the country as well, who are making really nice efforts they bring money, they bring themselves, they bring food. People have referred to this as the honeymoon period because that's what happens at weddings. People bring food, money, and come together as community. And so what happens in a crisis is people start to do better. But if they're not back to their baseline, it is an error to withdraw the support too soon. And the support that's going to be needed in Maui is going to be on the order not of weeks or months, but really of years. And if you withdraw the support too soon, first off, individuals who are just starting to recover but not yet back at their baseline, that's when a sense of helplessness is typically more in adults. And so we do see an increase in suicide and self-harm among adults, usually some months after a major natural disaster. So that is a particularly vulnerable period. But more likely what's going to happen is if you withdraw the support too soon, people simply don't get back to their baseline. And they may just stay at a lower level of functioning, which I just called here continued impairment. What we need to do is go beyond, help them until they at least reach where they were before at baseline. And for some individuals, not the majority, but for some individuals, if they have enough external support and enough internal resiliency, they may actually exceed their baseline coping. We call that post-traumatic growth. Individuals may emerge from crisis events different, but not damaged. They emerge with new resiliency, sometimes more empathy, sometimes more selflessness, sometimes increased spirituality, but they may become changed, but in positive ways that help them deal with future adversity and help others. I'm mentioning this because this is a lot of what has happened for pediatricians and other pediatric healthcare providers. Something happened during their childhood or the childhood of someone they cared about, and either no one helped them, or more likely someone did help them, and they've decided to devote their life to doing the same for others. So I'm going to give you kind of one last story. I was talking to a group of foster parents after a natural disaster on the East Coast. And one of the dads said, I think that's me. I think I went through post-traumatic growth. So he worked on Wall Street as a stockbroker. He was very successful. He said he was making a lot of money, and he was happily married, and he had a toddler, and he said life was like perfect. And then his toddler got an infection and died. And he said, and all of a sudden I questioned everything. And one of the things I questioned was what I was doing with my life. And he said, look, I make money for people who have money. I don't make the world a better place. I just make rich people richer. And in the process, I make a lot. And he said, that's a job. I want a career. I want to do something to make the world a better place. So he quit a successful job on Wall Street, went back to college to become a kindergarten teacher. He said, changing the life of a young child, that's a career. And then he became a foster parent, and he was adopting a child at the time. So he asked, is that post-traumatic growth? And I said, yes, it is. And while that is the best outcome you can get, it does indicate a vulnerability. Because as I said, a crisis can unsurface past crisis and loss. If you've gone through post-traumatic growth, you're one of those people who can unsurface that. And so that's what I wanted to end with, was talking about the importance of professional self-care. Because what puts us in helping professions is what makes us most vulnerable for being hurt by helping others. So we have to recognize that vulnerability and attend even more to professional self-care in our career than most. We have to recognize it is simply distressing to be with children and staff who are in distress. And it's critical professionals appreciate and address the impact of supporting children who are grieving, traumatized, or otherwise distressed. And we have to have a culture where it's okay to be upset when upsetting things happen, and where we normalize asking for help and model a willingness to accept that assistance. So that gets me to compassion fatigue. Exposure to the trauma and suffering of others can lead to what's called compassion fatigue. Empathy requires understanding and taking the perspective of another, but compassion goes beyond that, and it includes wanting to help and or desiring to relieve the suffering of another person. Compassion has its Latin roots to bear or suffer together. That's the co part of compassion. And so warnings about compassion fatigue tend to imply that compassion is somehow necessarily tiring or just exhausting. And then it's almost as if you care too much or too deeply or about too many people, you're just going to get burnt out. That's what I hear people say. The reality, though, is compassionate approaches can be gratifying. They actually bring meaning to the work that we do. I don't want to do pediatric care that isn't compassionate. I like the fact that it's called care. I think we should care. The patients deserve that, and we deserve that as well. But we have to have realistic objectives of the purpose of the interactions in order for it to be of best benefit, safest for us. So you need to, if you're helping someone that's in a crisis situation or has experienced a death, your goal is not to make them happy. That's unrealistic. Your goal is to help them begin to cope with the distress that they have. And you need to be able to see that and to be able to take pride in the fact that you're helping them start that process. We have to have the skills and the resources to provide meaningful assistance, whatever we consider meaningful assistance. And so if it turns out that our healthcare system, our pediatric practice, whatever, does not allow us to do what we feel is meaningful, or what's required, that's what causes also what we call moral injury. If you feel that people are telling you, no, you can't spend this much time with the family, no, you're not able to help them with this psychosocial need, so I don't want you to be paying attention to that, that makes us feel, causes us moral injury. So we have to make sure we're in practice settings that allow us to do what we consider to be meaningful. And this work is really difficult when you're in austere environments and when you have personal challenges. If you don't have your home, if you've lost some things financially as well. And then we have to be aware of and have sufficient support to deal with the personal impact of that work. But we have to recognize there are challenges. So it's hard to make time when there's so much to do and everyone seems to need your help, but you have to make the time so that you can continue to provide that assistance. People often feel shame or guilt for attending for their own needs ahead of their patients and others. We have to realize we need to take care of ourselves so we can take care of others. There's often a lot of assuming that others are having less trouble adjusting. Children will hide their distress, adults hide it even more, and pediatric healthcare providers hide it even more than most adults. But I will tell you, that is not a superpower. That's a problem. We need to be able to express that we have distress and seek and accept support. We don't need to share the details about the distress, but we need to share when we would like some more support. And then there's a lack of modeling of professional self-care. And when you send the slides, I will show you, you'll get these websites for more information, whether it's the National Center, the Coalition to Support Grieving Students that we coordinate, that has a lot of materials on how to support grief and loss in children, or the American Academy of Pediatrics website on children disasters, and the page specifically on coping and adjustment. There's a lot of resources there. There's this booklet on how to support grieving children. It's available now in 9 languages for PDF download and can be ordered for free in English or Spanish. Even the shipping and handling is free. We have tip cards on what to say and what not to say, which are also free. And I'm just ending with contact information for me and the National Center. So I'll stop there and see if there are any questions. And thank you for paying attention.
Thank you. Thank you so much for a really wide-ranging and incredibly thoughtful and I think practical and helpful conversation with us. There was a comment in the chat from Dr. Kelly Harnick saying, I've been the psychologist in Lahaina for 12 years. Before any fire, I cared about access to care a decade ago. I'm not sure if you mean like access to self-care, or if you wanted to clarify that at all. Feel free to unmute yourself, and then Dr. Rodolfo Begay has a question after that.
I'm assuming that part of it is just recognizing there were pre-existing issues with access to mental health services. I know they existed in Lahaina. To be honest, they exist virtually every place I've been. There are some places where there is better access than others, but they seem to be insufficient pretty much everywhere. And so that can be particularly frustrating when you now realize that the demand has gone up incrementally and the resources were never adequate to begin with. So I'm assuming that that's what she meant, but I do encourage her to let me know if there was something else. I think that can lead to some of the frustration that we were not well prepared. I would always say to people, often in emergency departments, mental health surge is considered one suicidal patient, and that can't be the case. I mean, we really have to be able to, we have to have a baseline capacity that is sufficient for what occurs naturally, and then we have to be able to surge beyond that when there are disasters. But one patient in your practice who has a severe mental illness or mental health crisis should not be putting you beyond what you're able to do in a surge. And so I think we have to restructure not only how we deliver mental health care, but we of course have to set a different priority and recognize that it's essential to what children need to be healthy.
Thank you. Dr. Begay, would you like to unmute yourself and ask your question?
Yes, absolutely. I know we're talking about the
I'm so
acute.
sorry. I just figured out how to unmute. I'm so sorry, everybody. I didn't mean to cut you off. Apologize, but I wanted to let you guys know I figured out how to unmute.
Did you have anything you wanted to add to the question that was asked?
Yeah, no, I'm so sorry to the other doctor. I just interrupted. I was having some technical problems figuring out how to unmute on my phone. But I think it's just, I appreciate everybody coming in and caring about Lahaina, but at the same time, let's be honest, like, about that consult, experience is, I'm the highest qualified psychologist in the state. I passed the PEP, I'm ABAPT, I'm MSCP'd, I'm ready to prescribe in 8 different states, and I'm in Lahaina for 12 years. And now all these people are descending on Lahaina. Well, and it feels like, it feels conflictual to me, because 12 years ago, nobody cared. There was no fire. Lahaina Civic Center was empty. Yeah, man, that's all there was. And we saw them pro bono, so people could be seen because I cared. And now all these people are descending, and it's like there's absolutely very little support for like the community providers. Like, we existed 12 years and made it through COVID because the community loves us. We provide good care. And everybody's coming in and it's great, but like, I'm a trauma specialist myself. I went to Hopkins. Like, I'm frustrated with everybody coming in from DOH and DOE, those places, and like nobody cared before. And so maybe the WHOI needs to understand, And I appreciate being invited and I appreciate being heard. And I'm not trying to be, pilikia or anything like that, but it's hard.
Well, let me
It's
just
really
comment.
hard.
Yeah. When our center goes to respond to a crisis, whether it's in a school or a community, our approach has always been that we do the best work if we do work behind the scenes to empower and support the professionals who are already there. So as a rule, we don't do anything directly with children. We're there to ask the professionals in the community, how can we be of assistance? Sometimes they would like some more training. Sometimes they'd like to be able to discuss
Right.
cases. Sometimes they'd like a little bit more backup. And
I think
so
you guys are way more pono than what I'm probably, like my countertransference is probably towards DOH and DOE for the kids and the keiki. And, you guys do an amazing job setting guidelines, best practices, and all kinds of stuff and coming in to help. It's more everyone else that,
it's frustrating. I understand.
yeah,
I think I know what you're talking about, which is this
Yeah.
sense of it. But part of it is also, to be quite honest, I don't think children want to talk to strangers that aren't going to be there for them. And
Right.
so we really do need to figure out how to support and buttress and help better prepare the people who have been there, who will remain there, so that we are not just creating a temporary solution to a longstanding problem,
Yeah.
because it's not that the children are going to get over what happened in Maui with the wildfires in a month or so. And so
Right.
a lot of people who come and volunteer and are deployed, often that decreases pretty quickly over time, and people they go someplace else when there's another major crisis. And the number of large-scale crises that are happening, whether they're man-made or natural disasters, is escalating and increasing in our country. And so it's not going to be that long, probably, before attention will start to shift to another
Right.
event. So I think as you come up with trying to figure out how to use the support that has been offered, which I think is helpful and is probably needed right now, you have to think about how you do that in a way that doesn't disrupt what's already in place. I've seen, for example, I'll give you one last example and then we'll go back to the other question. But there is when I was on a commission, a national commission, I became aware that when there is a disaster, families can qualify for emergency childcare support under certain federal means. But that money can only go to nonprofit childcare. And most childcare is actually for profit.
Exactly.
Kind of an
That's one of the
oxymoron
problems.
because they don't make very much money, but they are still a for-profit model. And as a result, sometimes funding goes to families and they take it because they need it, and they put their children in other childcare settings, which are then free to them. But what that does is it bankrupts the for-profit childcare that needs the money and never made much money to begin with. And then you actually degrade childcare resources in a community because you're trying to offer quality childcare. Not to mention the fact that
it's about being pulled on.
yeah, but children also should be with people they know and already have a relationship with, and they're trying to recover from a disaster. So the example that I gave is that has changed some, because now they make it a point of saying, and I saw that in Hawaii, in Maui, was they said we can only fund nonprofit childcare, but we can fund
Right.
nonprofit childcare to contract with for-profit childcare so that you're able to sustain the childcare system you have in place. So I do want to say that I think systems over time and governments can learn this, but I understand it's very frustrating to have outsiders come into your community and disrupt.
Nobody else is here, and then all of a sudden there's all these
Right.
people here.
With just in light of us being a few minutes over 1 o'clock, I was wondering if we could go on to let Dr. Begay ask his question real quick.
Sure.
Thank you so much, everyone, for your understanding.
Thank you. Actually, that discussion was very interesting. I was in New Orleans during Katrina, and I have a lot to say about that, but we can talk about that later. Actually, my kids who are not in medicine have a lot to say about that, and we can talk about that. My question, I know we're talking more about acute crisis, but I was wondering how this framework applies to the chronic problem of microaggressions, and if communities who are vulnerable and are experience microaggressions, if they respond differently to this acute crises.
Well, to the latter part of that question, we know that individuals who are already either feeling disenfranchised or are in poverty or already experiencing discrimination in one form or another are already more vulnerable and may have less reserves to be able to deal with additional stress. The way I tend to see it is more of a model of intersectionality, where they're dealing with multiple crises and stressors at the same time. And they also tend to live in communities that have fewer resources and capacities at baseline and less supports to help buttress them and help them with the recovery process. So to me, it isn't, I see it less as it's a fundamentally entirely different experience for people of different backgrounds than it is that their backgrounds and what they've had to deal with all along now just becomes even worse because of the additional and incremental stress. So kind of more of an intersectionality. That's at least the way I tend to frame it, because I think if we see people that have different stressors to begin with as somehow different people, and that the same type of strategies and approaches can't work for them because what they're experiencing is not the same, then we tend to not be able to provide help to as many people. So to me, I would say most of it has to do with kind of an intersectionality or a cumulative stressor effect that means they have lesser reserves. They often have had less opportunity to cope effectively with prior stressors, so they're less resilient. And so they don't experience the same extent of post-traumatic growth because they haven't been able to cope effectively yet. So I don't know if that answers your question, but that's the way I tend to view it, that individuals who already are dealing with, whether it's microaggressions or they've had frank discrimination or they've had poverty, that those are particularly vulnerable children and they need to be given even more resources and support so that they can cope with the same new stressor because they're already suffering at a disadvantage before it happened. I don't know if that answers your question at all.
Yeah, thank you.
Well, I'm sure we would have lots more questions, but I do want to be respectful of everyone's time. It's a few minutes after 1 o'clock. This was a really fantastic presentation. Dr. Schonfeld, I don't know if you can see the chat, but probably since you stopped sharing, you can see that there are many thank yous and expressions of appreciation for sharing all this information. I do want to remind everyone that the slides and some additional resources will be available on our website, hawaiiecho.info, and you can just navigate to PEDS and then resources. And I also want to let everyone know that the next pediatric echo on the 18th is going to cover the topic of WARI, wheezing-associated respiratory illness, and asthma in infants and toddlers with Dr. Brian Wu, who is actually here today listening to this talk, and we very much look forward to his talk. So thank you everyone for sticking around. Thank you so much, Dr. Schonfeld, for literally hopping on a plane within days after the fire and being such an incredible resource to all of us, and especially to our colleagues on Maui who are working so hard to support the Kekian families over there. And I see 7 new messages. I'm guessing that's a lot of thank yous. Yes, that is exactly what it is. So everyone have a good and productive day, and don't forget to take care of yourselves too.
Thank you. Thanks, everyone.
Bye-bye.